Okay, so far we've reviewed the first of the types of categories of cost control that are predominant currently in the United States. And we talked earlier about Yuval Reinhardt's important piece of research published in 2003, where he did a international comparison of the difference of some major issues about cost control strategies and healthcare systems in other countries, and found that in the United States, about 10% of our excessive costs or extra costs in the United States compared to other countries was due to increased volume of services. Our doctors were doing more prostatectomies, DNCs, coronary interventions. Uh, on the other hand, 90% of the difference was simply that we charge more for pretty much every procedure we do. So the one set of volume strategies, and so in the mainstream approaches, all of them seem to focus almost exclusively on volume, even though when you think about Reinhardt's research, it seems like we ought to go after prices because they're so deviantly high in the United States. And there, and it's largely failed. The first of the two strategies is basically say, okay, the volume here in the US is too high, and that's because the providers are ordering too many tests. So we're going to try to do things to prevent the providers, doctors in particular, from ordering too many tests. And so we started out with capitated systems like HMOs and continuing with basically capitated structures. Managed care was basically an intrusive insurance company, still private insurance companies, the same basic system with competing private insurance companies, but now they're going to intrude into care and require prior authorization, deny payment, and confine their patients to a smaller set of providers. And and they basically were given the power to decide what's medically necessary and became extremely aggressive and sometimes completely irrational about denying treatment. But the goal was providers order too many tests. We got to do something about it and rein them in. So we saw the era of managed care um, in the 1990s became unpopular, and now we have this value-based care. Um, and it and Dr. Bernheim presented the sort of epicenter of value-based care, which has been the Center for Medicare and Medicaid Innovation. One thing we haven't mentioned so far is that what Medicare does in the United States is often imitated sooner or later by private insurance companies. So stable private insurance companies like Blue Cross of Vermont and other companies across the country will start to try to have come up with value-based care systems and find ways to pay less if they can decide when they decide that something or other may not be necessary. So anyway, so that's sort of one issue. Two things about the value-based care model is that I don't know if you caught this, but when you have managed care was when your own insurance company is going to intrude. Value-based care is when your insurance company is not intruding, but another entity, external entity, is paid, your insurer and maybe even local hospitals and providers are paying into this additional administrative entity, an ACO, or one of these other entities that Dr. Bernheim's a group has created, a value-based care entity. And they say you're using a withhold structure where instead of paying the doctors 100% of their fee, you're only giving them 80%. The other 20% goes to this entity, which then either democratically or just by fiat decides how the money's going to be divvied up based on, in Medicare's case, some rules that Medicare uses. And so what I'm getting at is it's an administratively more complicated system because it adds another administrative entity. And the interesting thing is that both of them in the United States are allowed to be profit oriented, even private equity funded. So we have a Medicare only ACO just started last year I was saying in 2 different health systems in Vermont. And this one's funded exclusively by a company that got its capital exclusively from private equity capital. So this is really happening even in, quote, more liberal states. But I wanted to point out that the value-based care system arrangement came up with is even more complex because it added an entirely new set of administrative entities. So in general, going after providers has been, in political terms, has been currently more embraced by the mainstream version of the Democratic Party. However, the Republicans have not really complained about it. And on the other hand, the Republican Party, while it hasn't really objected to what the Democrats have been doing, they generally have other approaches which generally say, yeah, the volume's too high, but that's because people have too much health insurance. And let me get some light on here. So that may be something that no one in this internship has yet uttered. The idea that all these people we know are underinsured are often going bankrupt. But basically there's a whole whole group of health policy experts generally associated with the Republican Party. So at the Heritage Foundation, we have in this internship, on the final week of the internship, we have a couple people from the Benjamin Rush Institute who will tend to support these kinds of approaches. And so and they're going to have an hour and a half to present their ideas to you. So you'll get to hear it more persuasively from them than you will from me because I have issues with this, which I will lay out today, and you can come up with some. But basically the concept is Americans have too much health insurance. And let's say your coverage was 100%, leaving you with no copays and deductibles. The argument is that you're just going to go to the doctor for any damn thing. You'll just go. And I want to say that both the penalizing of doctors who get paid less in a value-based care system, and this approach, speaking as a doctor who's provided direct patient care, the idea of paying a group of doctors less who can't meet the quality standards that have been set up, it seems really limited because for the most part, what I've seen is that social determinants of health have a whole lot more to do with whether all those quality scores will be met. Poverty seems to me to be the biggest factor. And the most extreme version of that is homelessness, where if you take care of that population, your quality scores are just going to be horrendous no matter what you do. And you can make them have much better data, but it's just not going to go well. And so penalizing what are largely people who are willing to take care of the poor seems particularly nasty. It seems to me you might want to give them more money so that their patients can be brought up to what we view as quality standards. So this isn't a problem I have, I'll create my list of questions I have for Dr. Bernheim, and that certainly will go on it. Why don't you give them more money and help them? Anyway, uh, uh, over on the other side, you can also go after consumers. And let me just say, when you're talking about underserved populations, particularly when there's a linguistic, racial, or cultural difference, if you're not only uh, having those kinds of populations have all the issues they face in their lives be an obstacle to getting perfect care and every bit of preventive care and the rest that there is. If you're also going to construct financial barriers to them getting care, it's it's going to go even worse, and you're even going to see less, particularly in that population. Whereas wealthier people who are on the internet and just found out that they're supposed to start getting colonoscopies at age 45 rather than 50, then they'll take a day off from their job on Wall Street and, and go get their colonoscopy at age 45. So it's just very, very different populations. And the other obvious issue is that if you're very wealthy, then constructed financial barriers and high deductible plans will mean a lot less. So there's a real class issue and financial resources issue. And you always got to wonder if how much your little scheme or strategy is harming the people who are already doing the worst in our society. Macaulay, do you have a question?
Yes, I'm just trying to understand this perspective of the idea that Americans have too much insurance and people are going to the doctor too often. I genuinely want to know I know the way I'm going to phrase this question is going to sound sassy toward these imaginary people who are not in this conversation right now, but I genuinely want to know. I mean, like, where is the example of this problem? Like, are they just looking at our spending and seeing that it's high? Like, do we know anybody who goes to the doctor for fun and profit? Like, other than fringe cases like Munchausen's by proxy or something, people are not happy to be at the doctor, generally speaking. So, like, I guess I wonder genuinely how people arrive at that conclusion that people are getting too much healthcare actually, and maybe that's something that will come out in a later discussion, perhaps with somebody who is actually of that perspective. But it's just something that always surprises me. I don't know what the data is or even the anecdotal evidence is that's leading people to that belief.
It may be that during this internship, it's only the one group that'll meet with you on, I think July 16th is the day that they'll be meeting with you. And I think they're going to likely take that position. So you can ask them. It's hard for me to defend that idea because I don't really support it. And I mean, I've often made fun of it. If you want to be sarcastic, you could say, yeah, you know, I woke up the other morning and I just said, man, this gallbladder, I'm just tired of it. I want it out. I'm going in, gonna get it out. It's like, see, it's easy to make fun of it, but um, I, and let me, you actually, McCall, you said something in there that I think deserves more of a serious response. So they're having practiced in primary care and sort of grunt line care, or at most secondary care. I haven't been involved in tertiary care very much. So basically, you mentioned Munchausen's by proxy, and that's one of array of psychiatric conditions that involve somatic symptoms, bodily symptoms, conversion disorder, psychosomatic disorder, where but those are ones where people genuinely believe that something's really wrong and serious and needs an operation or needs serious ongoing continuing medical evaluation or more medical evaluation. A second group of people are often the most annoying kind. It's not a huge group, but people who can't work anymore and they're injured at work and they kind of fake it a little bit, and that's called malingering. that's not really a psychiatric disorder. That's taking advantage of the system. And you will see that sometimes. Many of those people actually, their bodies are worn out from years and years of work, and they're hurting now and they just can't go back. In some of those cases, they're being mistreated at work by an abusive boss. So they have other motives for not going back. But though, but uh, I think the number of people who are genuinely playing up symptoms, uh, other than when there's a financial motive, like maybe the workers' comp group, it's pretty small. And the other thing about them is that really makes this approach of going after the consumer and forcing them to pay a lot of money to enter the healthcare system an avowed goal of disincentive to care. People are overly overinsured. Um, what actually happens to those people is they end up in primary care, which is cheap. The primary care doctor might make a mistake, but most of the time they don't, and they'll start doing tests for somebody with unexplained symptoms. And yeah, that'll start costing some money, but once all the tests are normal, um, usually you start having to sort of focus on symptom control. There's a field called pain management that helps with that for people who have ongoing pain. But what I'm getting at is that they're not getting a coronary bypass operation. They're not getting their gallbladder out. They're staying at the inexpensive primary care level for the most part. And over the period of a year, yeah, probably things will come up and they'll end up with more spending than, some athlete who's perfectly healthy. But they're not going to get to those columns on the chart where the people are spending the most money, who 20% of the population uses up 80% of healthcare costs. Those are cancer patients. Those are people with lupus or MS or something like that. Those aren't people who are kind of, just carry a lot of symptoms and don't feel well. Those people are treated in primary care largely. And so and that's where, when you hear these theories, including the group who will be coming to this internship, I don't see very often that those individuals include many people who have experience in direct patient care. It's typically more they're economists, conservative economists, and sort of the work comes from there. So, and even the value-based care stuff, thinking about my experience, like, you're going to start moving around amounts of money. I'm going to work every day to provide good care the best I can. And I've stayed late, countless numbers of days because I needed more time to take care of the people who I was on my panel that day. And and this happens in all specialties. And so the threat of a malpractice suit on the one hand, or telling me I'm going to be penalized financially if I don't provide their standard of care, I'm just trying to do the best I can that day. You know what I mean? And all these external things, they're not really in it. I'm there for that patient. I'm doing the best I can. And and I do know of some interventions that I think can improve quality of care, but they don't have to do with money or legal threats. Anyway, so let me get into this. And I've already told you that I do have a bias, but some of the consequences of this kind of policy may not be obvious. But here's the theory that people need to have skin in the game, because if you have free care and there's absolutely no deductibles or copays, and people just go to the doctor for any damn thing. So another theory they have, a second thing, is there's too much regulation. This one I personally have sympathy with and agree with. I think, in the last part of today, I'm going to talk about what I think might be some solutions. But I think in the United States, our regulations could be some regulations needed, and I think it could be streamlined. But the approach that generally is taken on the political right in the United States is that they're complaining that the overregulation is not because there's too many inspections at the hospital, but that the insurance companies are overregulated. And if you deregulate insurance companies because of that histogram where the expensive people use up, 20% who are the most expensive use 80% or 75 of healthcare costs. If you start deregulating insurance companies, trust me, that pre-existing condition clause is going to go. And they'll cross state lines to find a cheap policy, maybe from an insurance company that doesn't even have a fund reserve. So if you actually get sick, they're off the map. Anyway, so just not requiring them to have a fund balance, allowing them to use the pre-existing condition clause, allowing them to have deceptive marketing, designing their benefit package so that obstetrics is excluded entirely. Like, you didn't have to get pregnant. Why should we cover that? I actually had a landlord the last time I rented who literally said that to me. She said, well, she was about 55, she's pretty conservative. She said, I don't think we should cover obstetric care. Like, I'll never get pregnant. I'm beyond that. And so I'd rather be in a health insurance plan that didn't cover obstetrics. So this is, that's kind of the thinking there, is that there's elective care and you just want to be in your group that's healthy. And so if you deregulate insurance companies, they'll come up with a plan that works well for healthy people. And we can talk about that a little bit. I mean, we already have that. The best way to do that is to have a huge deductible and big copays, and then all the people who are genuinely ill are going to try to find some other kind of coverage. So those plans will end up with healthy people, allowing them to lower the premium, make it more attractive, and after a few years, you end up with almost only healthy people. And that concept where all of the sick people are drawn to the company with the best insurance, and other competitors can thrive because of a weak benefit package, with avoiding covering things, and with huge deductibles, deterring sicker people from wanting the coverage. That leads to what's called a death spiral, where the insurance plan with the really good coverage got all the sick people, it dies because its premiums just go so high that nobody can afford it. So you'll hear that term, a death spiral, where insurance companies are picking up almost all the sicker people in a market. So that's a consequence of deregulating insurance companies in the United States. And I just want to say, you're going to be doing presentations in other countries. I think one of the things you're going to notice in the countries that do allow insurance plans is that they're actually not allowed to compete with each other and redesign, and their benefit packages will be intensely regulated with very high standards for what they're going to cover. So you may want to look for that when you're covering those countries that have insurance companies, like Switzerland, Germany, Netherlands, many others. Israel has 4 insurance companies. Anyway, so I think Japan works that way, but I'm not exactly sure. Okay, so another one is that there's not enough competition. So this kind of goes along with deregulation, that if you get insurance companies to compete, they'll change their benefit design, pre-existing condition clause, and then lead to some insurance companies that have much lower premiums. And as we just said, that can result in cheaper policies with skimpy coverage, so that if you actually get sick, they won't be there for you. But we like competition in the United States, so we kind of ignore those side effects. So another big complaint on the Republican side is generally.
Dr. Malik?
Yeah.
Could I ask a quick question? In terms of when you were talking about how other countries that allow private insurance but don't allow them to compete, what does that mean exactly?
I'm smiling because in those countries, it's sort of obvious, and here it's by no means obvious. Switzerland may be an exception. It's most deregulated country, other developed country, but most of them, there's a population they're assigned to, often based on historical events. And the German plan, for example, is now 140 years old, and it's based on unions in certain sectors of the economy. So, for example, in the United States, the United Mine Workers came close to having their own insurance plan. So every single mine worker ended up in the mine worker plan. And you didn't enter the plan if you were not a mine worker or a family member. And I think you had to be in the plan if you were in the UMW, the United Mine Workers Union. So that's an example of an insurance company that would not have competition. They had a plan, that was their plan. You know, and a lot of in the German ones, that's sort of their history too. There were certain groups of people that over 100 years ago, they would form, they were called sickness groups or something, sickness funds, I think was the name in Germany. And they would be for certain groups of people. In Germany, I think they have one sickness fund for the unemployed, but other sickness funds that are for certain group of workers. In France, on paper, France still has a system a little like that. So the agricultural people, the farm workers, agricultural people are in one group, but France has a lot of other rules that it's very odd, but it functions more like a single payer system. But its original history was that they had one fund that was going to provide fund for workers and I think other union-based symptoms or not symptoms, other industry-based coverage. And again, going back to the United States, Kaiser was an example of an organization. I think Kaiser originally was in aluminum, and they wanted their workers to get health care so they'd be healthier and come to work. And they formed their own insurance plan and ultimately got real serious about that. And it's kind of a prepaid system. And you could argue, if you think about the Veterans Administration, you can argue that that is both a set of hospitals and clinics, but also in a sense an insurance plan because they'll take care of all of the veterans' health needs if they're called fully served. If they're badly injured in the military, then they're sort of taken care of for the rest of their lives. And so in a sense, that's their insurance policy. And, you know, there's no competition there. It's the VA that provides it. Does that
Okay.
make sense?
Yeah, I think I understand what you're saying. In those systems, the insurance company will have a pre-designated population that they provide care for, and they're not competing to bring other people in and move people out, kind of thing.
Exactly. They're not competing for all the healthy people, which is the history in the United States of our competing system. However, I think when you guys do your international health, this model of essentially non-complete competing health insurance companies is not rare. And so when you see them, it's something you can say is how do they maintain that? And one of the ways I think Switzerland gets away with allowing competition by having very high standards for benefit. They're not allowed to have a pre-existing condition clause. They're not allowed to pick off healthy people. They're not allowed to have a skimpy, crappy benefit package that doesn't cover obstetrics or contraception. You know, there's high standards for what they have to do. And if everybody's providing a very, very high quality product, then there's no race to the bottom with crappy coverage to pick up all the healthy people. So that may be another strategy to accomplish that. And I consider that a form of regulation, government regulation. Here are the standards. You're going to do it, or we're going to decertify your product. So in your presentations next week, I hope you'll, if you're covering a country that has multiple insurance plans, how do they make it so that their people aren't left with really poor coverage in a skimpy plan? So I think that's a great question, and it's something I hope you'll be able to tell us next week when you study these other countries. Thank you for that question. Okay,
Thank you.
so here's one I strongly support. though I don't think it's financially wise, it's important. But Republicans generally support liability reform, though, as I mentioned, it's 1% in terms of its direct cost. You'll hear the term defensive medicine. This is where doctors are ordering tests they know aren't necessary because they fear they'll get sued. Anyway, and supposedly that's a whole nother percent. So if you had liability reform, you might knock off another percent. Maybe I'll just talk about it now because later today I have this in my group. I very strongly support reining in the malpractice system. We spend 10 times more on it in the United States than most other developed countries. It's not really benefiting our people. Defending people who sue, if you're not 65 years old yet, and say your child has a birth defect that was caused by poor obstetrical care, a bad performance by the obstetrician. Your child is now 0 years old, and let's say it's some kind of birth defect that is going to cause the child and eventually the adult to need more care for their entire life. This is the United States. If you have a 0-year-old child, an infant, and that child's facing 65 years of life before they're qualified for Medicare, you don't know how they're going to pay for that care when you just gave birth to the child. So you can sue, and there's 3 parts to the award in a malpractice suit. There's pain and suffering. You suffered because this person suffered because their terrible doctor made a mistake. So you can sue the doctor and come up with some financially equivalent for how much that pain and suffering are worth financially. The second thing is the patient missed work and is losing income because they can't do their job anymore. So if the child has a brain injury, then all the types of jobs that would involve high cognitive levels of function may be out of limits. That would be a harder thing to argue and a difficult suit. But on the other hand, let's say that the doctor operated on the wrong arm and the patient's not going to have one arm. You can there's an amount of money that's designated for each of these things. So you can't go to work, you're missing work, and that'll be included. And then the final thing is the child will get, for the rest of their life, they'll get paid, their medical care will get paid for issues related to that birth defect. And you can easily imagine that could be argued. Well, you're now getting, let's say they're 18 years old, they're getting a pap smear. That's not related to this, so we're not going to pay for that. So every single bit of care the patient gets through their entire life then could be litigated. You could say, well, this isn't. So that's too complicated. So what actually happens is they'll just throw a bunch of money in the malpractice suit that's going to be a fund to pay for this child's medical needs. So that's sort of an extreme case. Smaller cases would be medical issues. Sometimes it's clear what is related to the quote, to the error, which lawyers call it the injury. The injury is what the doctor made a mistake with, but we would call it the health problem that arose because of it. So anyway, it's demoralizes many doctors to variable extent. I already said that to me it doesn't impact my care because I'm already staying late to try to get everything right and not make a mistake. So doctors don't like it. It's unhelpful. It's not contributing to anybody's medical care to allow a system with so many lawsuits. So I strongly favor liability reform, but expect relatively little in terms of cost control. Sometimes when it's prevented by people who really support it, they'll tend to overstate the amount of money they expect to not spend in the U.S. on the basis of this. But this is often mentioned on the Republican side of the aisle. Okay, so, but they never really complain about what the Democrats are doing. They don't really complain about value-based care. It's just not their thing. And so this now gets into, we already had Macaulay's rule that everybody will feed at the healthcare trough who possibly can. And my rule is that when the mainstream wing of the Democratic Party and Republican Party agree on a health policy, it's generally either will be ineffective or unimportant. And anyway, you can test that rule out yourself. For those of you who read, there was a reading for today. It was an op-ed piece I wrote about health information, Tower of Babel. That's one of the few op-ed pieces I've written that's not in reaction to a specific event. Because I find it much easier to write an op-ed piece in response to something that actually happened, a new event. And I call that an entry or a hook. It's called a hook, where something happens where you make a point in it and your ultimate result is, and this all happened because of our completely dysfunctional healthcare system. Often the end of my op-ed piece will be, and it doesn't happen in any other developed country. So, but this piece I wrote in response to, I wrote it was published in 2012, and I wrote it after seeing what was clearly happening in terms of electronic health software. And I'll talk more about that later. And I hope you read that op-ed piece. Not very long, not that long. Okay, so, but anyway, all this value-based care stuff, the Republicans haven't really objected. And this is Obamacare. These are the exchanges. On the left, I think, are the bronze plan. On the right are the platinum plans, and silver and gold in the middle. These are really high levels of co-payments and deductibles. This is a lot of money where if you add up, like on the left, especially for the bronze plan, if you add up their deductibles and co-pays, they're paying 40%. Now, if they actually get sick and they're paying 40% of everything because of their product costs that are shared, that's a lot of money out of pocket. So this was what Obamacare was left with for all the exchange policies that cover, I don't know, 8 or 10%. Ken talked about that. I think it's 8 or 10% of the US population are now in an Obamacare insurance company and publicly subsidized with taxpayer money. But there's still a lot of copays and deductibles. If you're not wealthy, and most of the people in these exchanges are not real wealthy. Anyway, you can get, the government also subsidizes some of those copays and deductibles, but this is pretty high. And this is this is out of, I guess, the Democratic Party. So we see it here for both sides of the aisle politically. Okay, so this is the big policy, and the name of it is Health Saving Account Prepared with a High Deductible Health Plan. High Deductible Health Plan, it's sometimes called HDHP. If you see those letters in this alphabet soup, that's what they're called, High Deductible Health Plan, HDHP, and then the Health Savings Account. So this is the big policy, and I would bet that the individuals from the Benjamin Rush Institute that you'll be hearing about, they'll probably support it. So I'll raise issues with it, and hopefully they'll say what they believe if they support it, and you'll be able to hear a more positive spin. But I would like you to leave this talk with an understanding of what issues might arise. But let's start out so the theory is that the serious injuries and illnesses aren't avoidable. So the high deductible health plan is there to provide catastrophic care. And it would have really good coverage. So if you fall off the roof, then once you've used up your deductible for the year, everything would be covered and you wouldn't face a lot more expense. And the idea is that those kinds of things aren't really avoidable. But for all the little things, like going to the primary care doctor, because let's say you have a mole that really looks like, you looked online, it looks like a melanoma, and you go to the doctor, those kinds of stuff, that's more elective. You could go, you could not go, and you're going to control that money, and it's going to be that the cheaper stuff you could put into a savings account that the patient controls. So it's a savings account that you as a patient control. And when you go to the doctor for your first $5,000 of medical care in each year, you're going to pay, all the money that you're paying for that visit that's going to cover you is in that savings account. So it's not in your personal bank account. Like the average policy with like when I go to the doctor, I copay sometimes. I just give them $10, or or I give them my credit card, and it just comes out of my general, money. But here, this account is only for healthcare money, allowable healthcare costs, which is most of them. It might even allow some out of something like Tylenol that's not you don't need to go to the doctor for. But it's really confined to healthcare stuff. It might exclude massage therapy, or something like that, or it might even include it. But the point is, it's designated. But you'd have to look up the rules. I don't know them offhand. But basically, it covers most all medical expenses, and you use that money for your annual physical, for your mammogram. If you think you have a bad mole, it might be cancerous. And anyway, so it was a piece of legislation from the federal government that allowed health savings accounts, um, and to be formulated. They added an additional regulation that you're only eligible if you're enrolled in a high deductible plan. So if you had good insurance coverage, you couldn't use it. Can anyone guess why? Let's say they did allow you to have a tax-supported health savings account. Let me get into that. I think maybe in the next slide we'll just mention that. So this is an important feature, and we'll go back to the question in just a second. You can deduct the amount you deposit into the health savings account. So this raises the question of how is the money getting into the health savings account? And that answer is you write a check from your general savings, your checking account, your personal checking account, and you write it out, and it's going into your special account. So you're transferring money out of your general money into this health savings account. You keep track of that money, and it's tax deductible that year. So it's a tax deduction. So you can only use this if you're filing a 1040 thing. Because if you're going to use if you're not itemizing, I don't think you can use it. So you keep in each year, you can contribute money to it, and you can spend money out of it. And spend it on you could spend it on non-medical expenses, but in any year, if you spend it on something that's not medical and you get audited, you should pay tax on it. It goes in something you start having to pay taxes on. But if you use it on medical care, you never pay tax on it. And I just want to say that these government subsidies of insurance, which began in 1940s or 50s, I think, no, it was actually under Eisenhower, so it would have been the 1950s, where they allowed employer-based insurance plans. That money was never going to be taxed. And here you have health savings accounts that the government's never going to tax. This is a lot of money. This adds up to a lot of money. That act under Eisenhower, that was a lot of foregone revenue that the IRS otherwise would have gotten. So this is what I'm getting at in saying that is this is a huge subsidy by the federal government and state tax officials. This is a huge subsidy of the private health insurance industry. And if you try to deconstruct this, that lobby would be at your throat. I mean, this is a huge amount of money, and they'll fight for it. Just the way the real estate lobby fights for deductibility of, home health, home-related expenses, buying a house. So anyway, so this is the notion that it's tax-deductible money, and so it's essentially, in that sense, subsidized by the federal government. So now let's go back to the question. Whoa. May not have slides anymore. Let me look. Wow, this hasn't happened. Go back to Zoom. Stop my share. Here we go. So let's go back to the question I asked is, why do they require this only for high deductible plans? Why did they include that regulation?
Is it the idea that if you actually have a well-functioning insurance plan that doesn't have a high deductible, you'll be using that for your health spending, and you're just being able to keep the health saving account money for yourself as
That's
a
100% the idea. It's exactly the idea. That, you know, here's how that would work. It's exactly the thing. You would put putting money into this plan as a tax deduction when you're going through your life period of highest earnings, when you're in your 50s, say, and you know your earnings tend to be highest in the 50s, you know, from age 45 to 65. You'll have the highest annual income often. It's a common pattern. So you'll be putting money, let's say you had 100% coverage in your insurance plan. You'll keep putting money in this savings account. And if you're wealthy or in a reasonably high income tax group, you're basically holding on to money and you're drawing interest on it potentially for decades and the government's subsidizing it. So it's allowing you to build up the savings account. Maybe it's money you're never going to need for healthcare, but at least you're drawing interest on it for decades. This is the same principle of why insurance companies don't pay quickly. Because while that money's sitting in their account, or in this case in your account, your health savings account, it's in a bank or some facility, and it's giving you interest every year. And basically the structure of this plan, that's the structure of this plan, is that the government is subsidizing people who want to lower their income tax level. So this whole scheme applies largely to wealthy people. If you're poor and you're not itemizing your income tax, not this tax deductibility may not matter to you at all. So in this scheme, basically all taxpayers, including poorer people, are subsidizing accounts that largely benefit the wealthy the most, the people who are in the highest income tax brackets. So it's a remarkable reversal of progressive taxation, and it's essentially regressive. So but yeah, that's correct. So they don't want you just throwing money into the savings account. They want it to be an active healthcare fund. So I mean, I certainly agree with that legislation, but I have problems with the whole concept, which we'll get to some of the other issues. Okay, so the high deductible plan kicks in when you have a serious injury. Looks like, can't even tell what those are. It was billed as a skiing injury, but I don't look like normal skis. Anyway, this guy didn't go well on the mountain, so he has to go to the hospital, and his high deductible plan would kick in after he spent all the $5,000 in his health savings account, if he had the whole deal. Now those who developed the concept were really hoping that the employers, so if it's a $5,000 deductible, they were hoping that the employers would put in, I don't know, 2,500, and the employee would put in 2,500. And that was the hope, that the companies would actually help with this. And some do, but a lot don't. Anyway, and so that was the original conception. But whether it's attached to a health savings account or not, deductibles are rapidly rising in the United States. This is just a particular period of time, but even, you know, in this 9-year period, decade ago, that deductibles rose a lot, and they're continuing to, and that's a ongoing trend since this whole high deductible craze started in the late 1990s. It's been continuing and more and more of a problem, leading to underinsurance. Dr. Dolkart had a slide telling you about how over 70% of people who declare bankruptcy due to healthcare costs, they had private coverage at the beginning, and this high deductible stuff heavily contributes to that. So now we're getting into another problem with this type of policy is that not everybody's wealthy and can just afford it. So that's an issue. So the judicious purchasing, here's another issue, mainly affects primary care. Okay, so let's go back to the person who falls off the roof when they're cleaning out their gutter at 9 in the morning. So by 2 o'clock, they've already blown through $5,000 if they had a subdural hematoma evacuated. So there's no judicious purchasing going on. That neurosurgeon doesn't have to, just does his thing or his or her thing. And, the surgery happens. The patient no longer has any incentives at all for the entire year. And the lucrative specialties are largely unaffected. But what if the person, instead of having a bad injury on February 2nd and falling off the roof, what if they just went to a doctor for preventive care or management of high blood pressure, and they're paying out of pocket and they can't afford it, and it's 100% out of their pocket? So two things happen. One is the patient may opt out of getting their blood pressure properly treated. High blood pressure is extremely important. It's the highest risk factor for stroke. And so patients may opt out of really important care and often do, very often. But the other thing that goes on is one of the things that happens in primary care offices is that people with these kinds of plans, they'll start to negotiate with you. And I think the people who formulate this may have hoped that you would negotiate on cost and just say, well, you're poor, you can't afford this, you're in one of these, you have no coverage yet until you meet your deductible, so I'll charge less. And that often happens. But a lot of the negotiation often, the patient will say, do I really need this test? Like you started me on lisinopril or hydrochlorothiazide. Do I really need to check the potassium level? Like I eat a lot of bananas. I think I'm gonna not have it done. Anyway, so that's kind of what goes on in primary care offices. A lot of time spent on negotiation. Primary care is really hard. There's a huge agendas in primary care. All the quality stuff that they're measuring largely happens in primary care office. Like if you look at Dr. Gretchen, what's her name, Bernheim's list of quality measures, preventing hospital readmission for heart failure heavily falls on primary care. It's difficult and it's time consuming. And so so primary care is heavily burdened. And so negotiating with people who have a high deductible plan and they are looking to not spend the $5,000 that year, it can be really time consuming. So that's an issue. And people who support this plan, they often don't mention that. They just want you to be judicious in your consuming behavior. But here's what goes on. Kids with free care, no copays at all on the left, they're much, this is a double negative. This is kids who don't have a visit in the last year, and only 5% of younger kids who had no copays, and 15% of somewhat older kids, elementary school kids, will not have a doctor visit. But if you make them pay most of the cost, then a third of older kids and 13% of preschoolers, 18% of preschoolers will have not even a single doctor visit in the last year. So contending with high deductible plans is a real issue for kids, for getting everybody care, even children. So if we're at 10 o'clock, we should take a break. Yeah, we're beyond 10 o'clock. Okay, so it's 10:07. So let's break until I don't know, let's say 10:30. We'll break till 10:30. We'll get a good break. And we'll reconvene then. So far we've talked about provider-oriented cost control strategies, focusing on volume, getting providers to order fewer tests. And now we're talking about the patient or consumer, if you want to call them, the ones that focus on using financial incentives to prevent medical care that is elective. And the high deductible health plan is the center of that set of people who support that type of proposal. One of the issues with that proposal is that if you think about it, a majority of people, or a high proportion of people who are going to be really sick in the coming year, know that they're going to be sick. So this would not include somebody who falls off the roof and needs a subdural hematoma evacuated, but it includes a whole lot of people who, again, people who have cancer. If were getting chemotherapy last year, it's a good chance they're going to be expensive in the coming year. Same thing for people with lupus or many other chronic illnesses. Diabetes, those people will still have it the next year for the most part. So, so on the other hand, there are other people who are healthy and whose costs in any given year will be fairly low. And if you add up the healthy 70% of the population, they're only going to add up to about 9% of total healthcare costs. And they're the ones who will be paying out of a health savings account if they have one, or if they just have a high deductible plan and they don't have a health savings account, then they're paying everything out of pocket till they meet their deductible. That situation is now extremely common in the United States, where we have half the population basically under age 65 have a high deductible plan. And it may be more than that. Very few people really are not paying the first several hundred or even $1,000. So you're kind of going after the healthy 70%. And so being judicious about healthcare spending for somebody with multiple sclerosis just is not going to make sense at any point, because they're going to blow through that deductible, by February or March. And so what's the point? So you're basically going after people who are financially sensitive. They're not super wealthy. And the question I have is, if you're going after this 70% of the population who are only generating 9% of total healthcare costs, what would Willie Sutton say about that? I introduced him yesterday. He's the bank robber. And somebody asked him, why do you rob banks? Well, because that's where the money is. If I go to a tire store there, it's not going to be as much money as there is in a bank. So here, the people who have elective spending are pretty healthy, and they're only generating 9% of cost. So how much savings can you actually get out of this for a health policy expert who's looking to control healthcare costs? Well, you're limited to 9% of spending. And then the next question is, let's say some people in this healthy 70% are under age 40. A lot of them will be. If you just look at people under age 40, and again, that age group will tend to have incomes that are lower than people over 40 in general. Do you really want to discourage those people from going to the doctor for their first or second or third visit in a year? I mean, they're going in because, maybe even visits that look like they're not really necessary. Sometimes people come in, and in primary care often, or in the emergency department, if you're working there, somebody comes in and it's not obvious why. Like, what are you worried about? And sometimes a patient had was coughing a lot and had developed chest pain from coughing. And and they kind of knew that it wasn't much of anything. This was somebody who I think was 35 years old. And he said, well, my dad died at age 42 of a heart attack. And so I kind of get nervous when I have chest pain. And so we used that visit to talk about cardiovascular disease prevention, improving diet. Blood pressure was a little high, so we focused on that. Anyway, so what's the real agenda? And often the real agenda for teenagers, often the agenda will be some concern about a sexually transmitted disease, or maybe they're coming in because something related to substance abuse. At any rate, the biggest bang for the buck in terms of public health, is going to be from getting younger people on a healthier kind of road. And so this is where the community health centers are really important, connecting with younger people and having financial barriers like these are really obstructing that to some extent. And so, if you looked at the age groups that this is harming the most, it would be younger people. And why you're going after their fairly low healthcare costs is completely beyond me, or especially not children. So what we've seen out of this is deterring primary and preventive care on the one hand, and failing to control health costs on the other. So it's kind of a, worst of all worlds in that sense. And again, this is the graph that sort of gets at these people. So if you look at the 7 graphs, the 7 bars to the left, these are healthy people. Add them all up, 10% or something like that. You're not going after where the money is. And let me just say, one thing you're not going after is the amount of money that private equity investors are getting out of their investments in healthcare. That's not here either. So if you want to save money in the healthcare system, think about where the money is that's accomplishing the least. And I would say in the bank account of a private equity investor would rank higher in my calculus than deterring, a not very wealthy 21-year-old from going to the doctor for whatever reason she wants to. Whatever reason somebody who's, from my point of view, for whatever reason somebody under age 30 wants to go to the doctor, let them go. Take away the barriers, because for those of you who end up working in primary care, you're going to see, always try to ask the patient why, get at the real reason they're there. And very often it's something of real significance. And another one I didn't mention is often depression or anxiety. And you can get it, those kinds of family issues, or they're being sexually abused. Who knows what it is, but keeping them away from the doctor is a really poor idea from my point of view. So it diverts healthcare money in the form of tax subsidies to healthy people who earn tax subsidized interest on their savings accounts, while somebody with, say, multiple sclerosis is going to blow through their $5,000 account every year, never save anything, and they're still having to pay the premium for their health plan. And so they're spending a lot of money on their health care and never benefiting from the policy. So you're sort of diverting money to relatively healthy people for all the years that they're not going to have to spend very much. And then another group that really pushed for these high deductible accounts when the legislation first passed in the 1990s, or might even late 80s, the banking sector lobbied really heavily for this legislation, because that's where the health savings accounts were going to be situated. And banks earn money by holding onto your money and investing it, and earning more from their investments than you're going to get from the interest they give you. That's a big way they earn money. That's how they earn money. So they really wanted this legislation to pass. So with these accounts, you're diverting money generally from sick people to healthy people who are generally in higher income tax brackets where they care about having tax deductibility to the banking sector and to insurance companies. Because if you have a choice between this kind of plan and good quality coverage, if you're more ill, you're not going to take this kind of plan. When I was talking to somebody who was conservative about these plans, um, I basically said that why would somebody who has MS ever want one? And the response I got was, well, these plans aren't designed for those people. And it was like, okay. So this group of people in the bar on the right, you're saying that they're not even going to be in this pool of people, of insured people. So you're taking out the people who are really expensive. And what pool are they going to be in? And is the goal here for the insurance company to make money by systematically avoiding people who actually cost something that in the coming year? Like, this is the greatest deal on earth. It's like having a flood insurance company and you're only insuring people who are more than 100 miles from a body of water. Like, that's really a good deal, for the investor. So, I mean, this person said it with a straight face. We're not, we're not here for sick people. Well, why are they getting health insurance if your goal is for sick people to not be in the policy? I mean, that response just blew me away, but apparently that's something you hear often. Finally, these are administratively complicated. Like, until you hit the $5,000, you're gonna keep track of every dollar so that if you do hit the $5,000 that year, you're gonna start to get some coverage because, if you do get to $8,000, you want those last $3,000 to be covered. So it's a lot of administrative expense in these plans. Even at the bank, it's just a lot of activity. The poor quality coverage, as I said, outcompetes high quality coverage, which can lead to a death spiral for the high quality policy. And purchasing the policy will cost both the employer and the employee less. So they'll tend to take these policies. The employer, like I've had employers who really wanted me to get into these high deductible plans. I mean, they were really pushing it. And my last employer was a hospital, really trying to get their employees to have bad coverage. Oh, this is really great. Anyway, so this is what goes on. And so you can have this race to the bottom where the plans with really good coverage, first dollar coverage, they're not going to compete. They're going to get all the sick people, and you end up with a death spiral for those insurance companies and a race to the bottom for more poorer quality coverage. So, and obviously another issue is with high deductible plans is there's a whole lot of people who don't have a whole lot of discretionary money. And so the 60%, if you look at this graph, 60% of the population has total wealth of less than $16,200. This is now old. This is 10 years old. So, I think it's up to 23,000 now. So it's not a lot of money if somebody actually gets sick. For them to have to spend 5,000 just in that year and who knows what later. This is a meaningful amount of money for a lot of people. Okay. So that's the end of the part on the mainstream strategies. Those are going after volume of care, either by trying to get providers to order fewer tests with schemes like value-based care, or intrusive insurance companies and the more managed care like stuff, like in Medicare Advantage plans. That's one type of strategy. And then the consumer-oriented strategies to try to get people to use fewer services via a high deductible or big copays. That's the other strategy. And do you have any questions about those before we go on? Okay. I hope that doesn't mean that I'm not getting points across. Okay, so
Sorry, I
what
have
could be done? Go ahead.
something. Can you just clarify again what you mean about the when you say race to the bottom?
Okay, let's say there in your community there are two insurance companies, only two, and one of them is a plan where you pay your premium and the plan covers absolutely all medical care. So if you have MS and you're taking a drug that costs $150,000 a year, and a lot of cancer patients have drugs that cost way more than that, the plan just covers it. And the other insurance plan in your community is a high deductible plan, and you're getting cancer treatment, and it's November, it's the open enrollment period, and you're going to pick between those two policies. Even if you have to pay a somewhat higher premium, you're likely to take the good policy because you don't you don't have the $5,000 or whatever the deductible is. I knew a doctor once who had a plan with a deductible of 10,000. So if you're really sick, you're going to want to have good quality coverage. You're going to have coverage that doesn't have restrict you to networks of doctors, that doesn't have cost a lot if you end up in the hospital with a lot of out-of-pocket payments. And keep in mind, when I say $5,000 deductible, that's just the deductible. We didn't talk about co-pays. A lot of these crappy plans will have 20% co-insurance means you pay a percentage of the fee. Co-pay is usually a flat fee. So if you have to pay $10 to go to your primary care doctor, it's just $10. But when you're paying a percentage of what's called co-insurance, and it's a drug that costs $120,000 a year, if your co-insurance is 20%, you're paying $24,000. So that's a lot of money. So the sick people, the sickest people, are all going to go into the high quality plan. So again, getting back to try to go back. Doesn't want, yeah. So going back to this graph, which is the most important one you're going to get in this internship. So everybody in the graph on the right, if they have any reason to think they're going to be there, they're going to take the high quality coverage. And if everybody who's got, drugs that cost $200,000 a year is going in the high quality plan, and almost all and people are sensitive to how much they're paying in premiums, and they're really, really healthy and didn't even, I've had years when I didn't go to the doctor at all, a couple of years ago, actually. So if that's the case, I'm not going to pay more in premium to get a high quality plan. I'm going to pay the lower premium and get the crappy plan because I'm saving all that money on premium. I'm with all the healthy people in this other plan. Because keep in mind, this high quality plan is in a death spiral. They're getting all the people who know they're ill. So these costs can really bifurcate pretty quickly and polarize so that all the healthy people, more and more of these people over here are going to say, well, I don't want to be in this plan that's so expensive. It's got all those sicker people. So that's kind of the concept of the death spiral. It's an insurance company that's attracting everybody who's really, really ill. And it's because of the consequences of this graph. That a substantial portion of people on that bar number 10 who are really sick, substantial portion of people in there know that they're going to be there next year. Does that help?
Yeah, that makes sense. Absolutely. Um, in terms of like the analogy that you were using, the race to the bottom, does that mean they're racing to have the people who will cost less? That what you were trying to get across there?
Maybe that term is used, but maybe I keep getting my choice of words improved, criticized and improved. Um, Race, bottom you can understand. Bottom means poor coverage, high deductibles and copays. Using the term race, maybe that's not the right term because it's not really a race. It's devolving over a period of 2 or 3 years. In each, because most people annually decide on what their insurance plan is going to be for the next year. It's usually done in annual increments. There's like, and even in Medicare, there's an open enrollment period once a year. So it's a pretty slow when we're talking about period, but it only takes 2 or 3 years for this to bifurcate. And I gave you an extreme situation where there's only two insurance companies. One has fabulous coverage, the other has, very high deductible plan. I mean, that's an extreme situation. And in that situation, it might bifurcate in only 2 or 3 years, where all the sick people, again, absorbing 62% of health costs, if really all of them bifurcated, which they probably would. And by the way, the insurance terminology is called adverse selection, where, if it's flood insurance, the people in the most flood prone areas, they all buy that insurance. It's called adverse selection. And the same thing in healthcare, where all the sick people go into a certain plan. So high quality coverage leads to adverse selection, and low quality coverage leads to, I think the term is propitious selection or favorable selection, where all the low risk people go into a different policy, which is usually low in quality. So yeah, I agree that the use of the word race, it's not a race, it's not running fast, it's done over a period of 2 or 3 years. So yeah.
Gotcha. Thank you.
Yeah. Any other questions? All right. So I wish I could have this slide. I should just put this slide in every other slide so I can keep going back to it, because you can see this is really critical to understanding health insurance related health policy. Oh, by the way, we didn't cover this. So out-of-pocket costs are particularly high in the United States because of these deductibles and copays. Canada's pretty bad because they don't have insurance coverage for drugs or home care or a lot of other long-term care or dental. So it's not in their regular healthcare system. We're gonna have a speaker on Canada in 12 days, so you can ask her more about that. Anyway, so Switzerland also has very high out-of-pocket costs because kind of a fairly weak healthcare system. Anyway, so what might work? Again, my criteria. Number one, can't be bad for patients, even patients who are poor. Number two, can't burn out providers. So this prior authorization stuff out. If you care about your primary care workforce, you don't allow insurance companies to do whatever they feel like doing with onerous administrative burdens like prior authorization and many other things that go on. But that's sort of top of the list. So here are my criteria. Oops. Here are my criteria. Number one, don't rely on one strategy. This is going to be really hard. And number 6 on that list is fight for every percent that goes along with it. Find as many ways as possible, even if they seem little, like the malpractice thing. If you have malpractice liability reform, won't hurt a single patient, make doctors a little happier, fine, let's do it. Any strategy that is not harming patients, not burning out doctors, do it. So evaluate every strategy, be ready to modify, change, adapt. If something's not working out, change it. So, if somebody comes into this internship and says, oh, single payer healthcare, solve every problem. No, you look at it. When it gets implemented, make sure it's working. People are unhappy with something. When you look at these other countries, you're going to find a lot of unhappiness with each system. And if you're in a system that's well constructed, it needs to be able to handle that, to find out what's wrong with the healthcare system. So one thing that should be done every year is a satisfaction survey that goes to both providers of care. What don't you like about this healthcare system? And same thing for patients. Do you feel like this system is helping you get the care you need? Be ready to fight. Number 3, be ready to fight entrenched interests, because all of Macaulay's pigs that are at the pig trough, everybody trying to go for the healthcare money, you got to be ready to fight them. You're going to see that very shortly. Finally, another one. When we just went over this high deductible plan stuff, if you noticed it, if when I said how this differentially impacts primary care providers versus neurosurgeons, when those economists come and meet with you here in this internship on July 16th, how many of them ever thought about that? How many of them have any understanding of how this policy that sounds so good to them, medical savings account, high deductible, how this is going to impact primary care? Do they care? Do they know? So get ideas from the trenches, not the ivory tower. And then look at models from abroad because there's a much lower cost in other countries. How is it that they're doing that, accomplishing that, and yet covering their entire populations? So these are my principles. Adapt, be ready to adapt. Don't get too drawn to one policy versus another. And be ready to change it. Don't hurt patients, in other words. Okay, so higher costs in the US, 10% due to more elective or unnecessary procedures. Following my 1% rule, you should go after it because that's 10%. So if you've got a way that's not as administratively complicated as one of these value-based care models where everybody's, generating administrative costs to figure out, what in God's name is going on, which Dr. Bernheim unfortunately didn't get to in her talk. Don't make it administratively complicated, but if there's some simpler way, I can propose one. I think if we had extremely high quality software and there were a way, which there may be within 20 years, to get AI involved in the software, it's possible you might get better guidance if the thing could analyze the data you're entering. So that, I'm kind of cautious about supporting AI because in healthcare in the United States, whatever's new always ends up adding to costs rather than not. But, it's possible that very high quality software could help to direct evaluations more effectively. And we can talk about that more later if you're interested. So that might help with 5 to 10%. Higher prices for those procedures is extremely important. I think this might be an underestimate. Vastly higher administrative costs, higher prices in drugs, prostheses, coronary stents, everything that enters the US healthcare system is expensive, and then higher malpractice costs. So our administrative costs are especially high compared to some other developed countries. Wales and Scotland and Canada have single payer systems, so they're extremely low. Netherlands has insurance companies, more complicated systems, so they have higher administrative costs. Again, Switzerland on the right here, they have multiple insurance companies. Germany does too, so they're more complicated. Australia is a weird one. Is anybody covering Australia? You are? Okay, then I won't say another word. You'll see why their administrative costs are a little higher. Okay, so this graph, the yellow line, yellow part of this temporal graph, starting 1970, ending in 2017, shows the growth of physicians in the United States. So that's the yellow one. The powder blue one shows the growth of administrators in the United States. So notice in the 1990s with managed care, that was the era of the peak, the height of growth, at least, of intrusive insurance companies and managed care. So that led to a big growth in the number of administrative employees, manager employees, mid-level management, and those kinds of things. And it never went back down because intrusive insurance companies never went away. This little bulge at the end, I will be interested to follow this further because I'm sort of wondering if that's got to do with value-based care. Because keep in mind that value-based care, the Medicare models and other models, add another entity. Remember that. You still have an insurance company just paying, and then you have another entity being the value-based care entity. So that's adding a lot of administrative costs, manipulating what the money is to try to get rid of fee-for-service and get you to get less money if you order a lot of tests. So it's financially kind of complicated. So I'm wondering if this actually is statistically significant, this little bump at the end representing value-based care. But notice most of this graph the trend is always upward because we never do anything to reduce it, basically. So endless number of jobs in the US healthcare system. Everyone gets their cut. The stockholders do, and much more of our healthcare money goes to for-profit investors, private equity, all of that. And here's one we haven't talked about as much. You're going to meet with the CEO, the man who was CEO of Springfield Hospital when it went into Chapter 11 bankruptcy. And what had happened here is to get out of Blue Cross's community pool. So Dr. Dolkar talked about community rating, where everyone in the community is in a big risk pool, versus experience rating, where an insurance company offers a product to specific businesses, and the business might want to not be in Blue Cross's big risk pool because they think their employees are healthier than the big risk pool. And most of the time they're right. So this gets into something called self-administered plans. They're covered under federal legislation, so state insurers have very little power over them. That legislation is called the Employee Retirement and whatever the rest is, but its initials are ERISA. So it's called ERISA. And all the self-insured plans are regulated by ERISA. And it's a strategy to get their employees into their own insured risk pool. They've pulled out of the general one that insurance companies would be offering. So what might make that risky for an employer to say, the general insurance, Blue Cross for the state of Vermont, the policy is too expensive. I think I can do better because my employees seem to be healthy. What might make that risky?
I mean, they're betting on that continuing to be true. Random things can happen that can disrupt people's health.
Stuff comes up, things can happen. And let me just put out there, any other thoughts on what might make that risky for an employer to do? Let me give you a clue. So Walmart and FedEx, they all self-insure. I think the multi-state companies that offer policies that they're basically self-insuring throughout the country, they're all in this ERISA group too, the self-insuring. And the advantage Walmart has is statistical. Their denominator is so large, they have so many employees, that Macaulay's idea that say a company only has 7 employees and they self-insure. Yeah, you don't know, one of them could get sick. And out of 7 employees, if one of them needs a heart transplant, I mean, you can only imagine what happens to that employer who's taken a chance. So it turned out that this hospital has 750 employees. I brought this up before. And so they thought they could do better than the general risk pool, so they self-administered. But they knew their denominator of 750, that's still too small. 7's too small, 70's too small, 750 is too small. I think when you get to 750,000 employees, it's starting to not be too small. But 750 was not going to do the trick. So there was a lot of risk. And so they bought another kind of policy. The hospital bought something called reinsurance, where there's only a few reinsurance companies, I think, in the whole world. The famous one is Barclays of London, and they insure insurance companies that don't have a big enough denominator. Now, the reason I bring this up is because in a country with a single payer system, this is a cost that doesn't exist. This is an administrative cost. So the fact that Springfield Hospital found it more advantageous to pay for reinsurance than to join the general risk pool, led them to divert some of their money from the care of patients at that hospital to, say, it was Barclays of London. So they're diverting their money to this reinsurance, this huge reinsurance company. So my analysis of this is an unnecessary administrative cost. Because if we brought everyone into a single risk pool and it was a national risk pool, nobody would have to spend that money. And what you're going to hear from Josh Dufresne next week, the CEO, is the coverage didn't work out very well. And if you're interested, you can get into that. He'll have a lot to say. He's a great guy and he's a lot of fun. So I'm sure you'll enjoy this session. But anyway, let's try to ask him, well, why did Springfield Hospital go bankrupt? What were the reasons? And anyway, so this is one of them. This is yet another administrative cost. The value-based care stuff, that's adding administrative costs. So we just keep adding them on and compare this to single payer healthcare. And the definition there is it's universal. Everyone is in. There's no administrative costs spent by insurance companies doing advertising to pick off one group over another. There's no segmentation of insurance plans into the good ones and the bad ones. Everyone is simply in. So you don't have to go through an enrollment period every year because everyone's enrolled. So you're saving that administrative cost. All that activity, all the letters that get exchanged, all the meetings where somebody from the insurance company comes to the employers and to the employees and tells them all about it. Everyone's in, it's universal. It has to be comprehensive. Okay, so let's say you had a plan like a bronze plan, or even any of those plans, even the platinum one with 10% copays. That can be expensive. So if your coverage is universal, but it's not real good coverage and it's leaving everybody with big copays like Medicare, leaving huge potential copays, 20% coinsurance is the way it is in Medicare Part B, which is where most spending in Medicare is now. If patients have unlimited out-of-pocket payments, what might they want to do? If they want health, financial security and yet have coverage.
Get insurance.
Pardon?
I was just saying, you were saying if they had this possible potential liability out there, they may want to get insurance.
Exactly. They'd want a better insurance plan, or in the case of Medicare, they are forced to buy supplemental insurance. But if you guys are activists for like years and years and we finally have a single payer plan, if you're going to leave a crappy benefit package that has potentially high copays, I'll just arbitrarily say more than $1,000 a year, where people, are subject to $2,000, $3,000 a year. and the higher that gets, especially if it's unlimited, people are going to want to buy a supplemental insurance plan. And that's what we have in Medicare. I told you I spend $2,000 a year for supplemental insurance because I don't want an unlimited 20% copay. What if I actually need some kind of chemotherapy? Yeah. So they'd want a better insurance plan. So the way you phrased it, Chris, you might be more activist oriented, probably why you're in this internship. And so you might say, we're going to lobby to make our single payer plan better and have high quality coverage. That's one avenue. But in the short term, or due to lobbying, maybe I can guarantee you that insurance companies want that if we had a single payer system, would fight really hard to have poor benefit package so that there would be a room for them to make money out of the healthcare system. So the co-pays need to be really modest, or you're going to end up with supplemental insurance policies. So you could have $5 co-payments, and that nobody's going to buy health insurance, a supplemental plan for that. That gets criticized because there actually is some administrative cost. You need somebody to collect the money in the practice. If a primary care practice has $5 cash deductible, somebody has to take that money. There'll be some patients who forget to bring money, so then they have bills. So that can be criticized as adding to administrative cost. But if you have such bad coverage that people are buying supplemental plans, like I am Medicare B, okay, so now let's go to the doctor. Let's say I'm going to the doctor, my primary care doctor, and when I get to the doctor, what's the first thing that happens in a doctor's office? In most countries, and especially the United States. You walk in, and what happens first?
They ask you to confirm your insurance information and who's going to be paying for it and paying your deductible or copay upfront.
A wallet biopsy. You're exactly right. They want to know what insurance card you have. So when I go, I show them not one card, but two. I show them my card for Medicare B or Medicare, and I show them this other card from the insurance company that provides my supplemental insurance. So now in the back office in the doctor, so that day the doctor generates a fee, like that was a comprehensive visit. So we have such and such a fee, $290, whatever it is. And in the billing office, that then gets sent in two directions. And for whatever reason, if one of them doesn't, there's more likelihood that one or the other of them won't pay. So what I'm getting at is that by having such poor coverage that people are motivated to buy supplemental plans, you're throwing this onto the primary care office and all the other providers. They're all going to biopsy your wallet because that's the first thing that happens. They're all going to discover you have two forms of insurance. And if they accept Medicare, they're going to have to bill both. So what I'm getting at is that you're actually saving money by having comprehensive coverage because the doctor's office only has one insurer to deal with. Furthermore, if that insurer is the government, they're not going to go do the shenanigans that denials of coverage and all this other stuff that goes on with private insurance companies to delay payment, deny claims. So in general, public systems pay much more promptly, and there's much less going on about denying care and trying to get out of pain. So having comprehensive coverage saves money. To have every single patient in the same system saves money. That's not intuitive, right? You would think to leave out whole groups of people or to have crappy coverage would lower the cost, but I'm talking about total cost to the system. The amount of money we devote to healthcare in the United States. So universal comprehensive coverage, ironically, if you're looking at total system cost, it saves money by getting rid of all this activity that goes on in provider offices, in hospitals, and elsewhere. So public financing is universal. That's the basis of the financing of the single payer system. And the delivery of care could be either in the private sector, as it is in Canada, or in the public sector, as it is in Spain and England, where all the doctors, their paycheck comes from the National Health Service. And we'll have a speaker later in the internship arguing that a National Health Service public sector delivery of healthcare is probably better. But, you know, you can ask questions there that he'd want more of England rather than the Canada variety. Canada, everybody pretty much in Canada who delivers care is in the private sector. There are exceptions. There's an Indian Health Service for their First Nation, what they call First Nations. Okay, it's portable. So if you change jobs, nothing happens. You go from one job to another, nothing happens. There's no letters, no insurance cards, no period of time when you're not covered. You don't have to worry about it. It goes with you. If you move, the insurance goes with you. And you may have to tell them about an address change. If there's a birth or death, they need to know about that. But other than that, it's fairly minor demographic information. And accountability is critical. Earlier on, I told you that you need to actively seek out feedback from doctors and from and other healthcare providers, as well as from patients, so the system can adapt. And that's very difficult to do. And as you can imagine, in many countries, every country you're going to study, there's complaining. And the question is, how can you create a system that responds to dissatisfactions most effectively? It's very difficult, but it's